Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I'm joined by my delightful and decadent co host, Dr. Susan Hudson from Texas Fertility Center,
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las
Hi,
Vegas.
guys.
So, Carrie, I don't know if we really should say you're from Las Vegas anymore because you've traveled more in the last few months than I think I've traveled in the last year and a half. Every time I hear from you, you're from some new place. So the most recent traveling was Orlando, right?
Uh-huh. So I was lecturing at a conference. So it's the Society for Ethics in Egg Donation and Surrogacy. And
Oh,
so
wow.
I was giving a talk on some of the new things that are coming out with genetic testing, like the life view that we do, which is a lot more specific than NGS in looking at
Yeah.
PGTA. And so I was on a panel with an embryologist and a doc. And so, we had a great time and talked and got to connect with people that I never otherwise get to see. And so, but my goal on this trip was I wanted to do 36 hours out and back and be done. And so
But it didn't
they
quite work
That
out
didn't
that
work
way,
out
did
too
it?
well
I
for
saw
you.
your Instagram.
that did not work out well at all. And so I got to the airport at, I don't know, 6 p.m. on a Thursday, with the intent of I'm going to be back in Vegas at 10 p.m. Vegas time so that Friday I have surgery, I have a full clinic, I have another training to do. Like I gotta
A lot of
go
stuff.
and
Yeah.
be around for my family. So as I am getting to my gate, the sky opens up and all hell breaks loose. And it's
Yeah.
just a huge storm that's got lots of thunder and lightning. And so, of course, the
Mm.
entire airport got shut down. And the airline that I was flying, which shall remain nameless, but is a yellow boil on the behind of airports everywhere, um, they they shut down all the flights. That part I get. Everybody was shut down, fine.
Yeah.
And so they say we're going to leave 2.5 hours later. No biggie, fine. So it's 2.5 hours later and they shift our gates, and then they say it's going to be another hour, and then it's going to be another hour and a half, and so on. And so right before our flight was supposed to take off, there was another international flight that they boarded, which then sat at the gate for at least an hour afterwards, not going anywhere. And so
And then
the
it
flight
knocked you out.
the attendants said, okay, you guys, your flight back to Vegas is going to leave in, 1 hour. We have a plane, we have a crew. Everybody cheers, everyone's ecstatic. They get this other flight boarded, the gate agents leave, and they disappear. And then about 20 minutes later, we all start getting emails, your flight has been canceled.
Oh.
Oh, you're kidding.
Yeah, it was a jerk move. It
So
was a
they've exceeded their length of time that they could work or something, or just they knew all
I
along?
I have no idea because everybody left.
Mm.
Wow. Yeah,
Yeah.
that's really poor customer support. Really
So
poor.
so I spent the night in the Orlando airport because by the time they made that final determination, it was 2 a.m.
Are
And
Oh,
you serious? How long had you been in the airport?
I got there at 6 p.m.
eight
Wow.
hours.
Yeah.
That's
And so
miserable. It is a good
I
airport though, so at least
I was not a fan.
oh
Maybe it was
really?
just the terminal I was in, but I was not a fan. And so we ended up, but fortunately, my husband and I had been talking earlier in the evening, and we had booked a backup Southwest flight the next morning, kind of seeing that this might go this way. And so,
Yeah, that was a good idea.
so I would say I slept in the airport, but I didn't sleep at all. I just,
Oh
sat there
man.
twiddling my fingers. I stood in lines for several hours to try and get refunds and all of that. Like, was not impressed.
So, Carrie, just
Yeah.
because I've known you for a few years now, you tend to have a little bit of a black cloud when it comes to traveling.
A little bit.
You do. You do. I mean, like, I'm wondering, is it like because you're flying to Vegas or is it just special to you?
I so
Hey, coming back from Europe, when you came back from Europe, what, a couple of weeks ago, or whenever that was?
I mean, to be fair, I got to a week ago. I made a trip to London, to Cologne, then to Berlin, then to Brussels, then back to London, back to Vegas without a hitch.
Yeah.
Okay, that's good. That's
And
good.
so that was good. And I got to my Palm Springs lecture without a hitch and all of that. But yeah, at least this time I kind of saw it coming and had a backup plan. And so I was not in pieces, which is what I was the last time that you saw me, Susan, because I had been gone for
It
a
was
week
it
and
was
missed
not a good day. It was not a good day.
day. I was like, all I want to do is see my kids and my husband. And yeah, but this time I was really quite calm because I'm like, there's not a thing I can do. And this is whatever.
Yeah. Sometimes you just have to say it's out of my control. There's nothing I can
Yeah.
do, but
Yeah.
that's
Like,
miserable. Well,
excellent.
Susan, do you have any questions for us today to talk
I
about?
do. All right. I am 39. Hubby is 45. I had 2 sons in my 20s. No issues. In the past year, I experienced 1 miscarriage and a chemical pregnancy. I found out I have antiphospholipid antibody syndrome, and she has Hashimoto's. My husband has a low sperm count due to testosterone treatment. He's been on Clomid and HCG, and she'll be on Lovenox once she has BFP. We have failed 2 IUIs. I've been on Femara 2.5 milligrams days 3 through 7 to start the 3rd IUI. IVF was recommended. Insurance covers IUI, only costs $40, but does not cover IVF. Emotionally, it's been hard to wrap my head around that we even need these interventions. My question is, with my age, APS, Hashimoto's, along with the interventions, is IVF the best option? Any recommendations for the emotional side?
Oh, so for the emotional side, tap into people in your community who have been there, done this. And I would say just about every city, talking to colleagues, every city has a Facebook group, which is, infertility in Las Vegas or, Vegas fertility treatment, whatever it may be, that you can tap into as a patient. And so it's people who have been there and have done that and who kind of know. Resolve is the national organization. That's another way to tap into people, but
There should be local chapters too. I know we have a local chapter of Resolve in our community as well.
Right.
mhm. If you're part of religious groups, sometimes they have a support system to tap into. If you're in any major academic place with women who tend to be in that demographic, like fertility treatment ends up being really common. So sometimes it's just a couple well-placed comments in the break room or the lunchroom, and you figure out, okay, who's my community. Always the professionals, the therapists, psychologists, psychiatrists, social workers, they can all help as well. So, but definitely, I'm so glad you're asking about that. And there's support in all ways, shapes, and forms. You just got to look around a little bit because it's not always super obvious.
I think the biggest thing in finding your community is realizing that 1 in 7 to 8 couples does have trouble conceiving. So although it feels like everybody around you is having babies, that's not actually the case. There have been a lot of people who have struggled, and there's a lot of people who have struggled in silence. And oftentimes they're just as happy to talk to you as what you're wanting to talk to them. And knowing that it is a journey, and it's a journey that is actually best shared with select individuals.
And two, it's interesting, some of the good side to infertility treatment, we've actually had patients who've become friends because they see their friends or they make friends from patients that they see in our office, like when they're sitting there waiting for their ultrasounds. And so I think sometimes, I think for me personally, for things like that, I think having a person there physically who's sort of gone through the same things you have, I think it really helps to kind of get through that. As far as the age, again, if you look around at our clinics, you are certainly not in the minority. A long time ago, maybe 25, 30 years ago, a 39-year-old woman wanting to get pregnant was really unique, but now that's pretty much the norm in our clinics. And so, we have younger women certainly that have fertility problems, but we have lots and lots of women in their mid to late 30s. So, I think from an age standpoint, I think one of her questions was, should I think about IVF? And I think, as we've said before, sometimes it's an emotional decision, sometimes it's a financial decision. In fact, that's going to lead right into what we're going to talk about today is how do I make the decision to do IVF? And so I think you have to look at some of those things to kind of really make that decision. But we do know that IVF is the quickest route to pregnancy and it's the most successful. So we do tend to lean people into that direction. And so to that end, since this is the topic we're going to talk about, our topic today, and I don't think I said the name of the topic, but it's questions you should ask yourself before you proceed to IVF. And so, again, there's a lot of different factors that play a role. So, some of the things you may want to ask yourself, Susan, do you want to start out? What's a question you want to ask yourself before you decide if IVF is right for you or not?
is time, or this is kind of going straight from this, what our listener's question is time important? Okay. If I'm sitting there at, in my upper 30s and, I've had recurrent pregnancy loss, and understanding every time I lose a pregnancy, I'm going to lose 1, 2, maybe 3 months of, momentum, that time may be more important, that I need to have things happen more expeditiously, or time could be important because of what my future plans are. My future plans, if I'm sitting here at 26 and I want to have 4 children and I have, endometriosis or diminished ovarian reserve, or maybe my partner is significantly older than I am, these are all things that, like, when time becomes a big deal, IVF often has some substantial benefits. IVF, along the whole time thing. Also, if you're planning for the future, I want to get pregnant now, but the next pregnancy is going to be at a time that maybe I won't be in as good a position. So say I'm getting pregnant now that I'm 32, and I don't want to have another child for 2, 3 years. And then I'm going to be, 35, 36, maybe that IVF is a good option for the timing factor.
All right. So timing is definitely important. And you kind of hit upon age a little bit, Carrie. Can you say a little bit more about age, how that impacts your decision?
Yeah, and a lot of it goes back to family planning. So, for example, if you have someone who is 26 years old, then you have the time to screw around and find out. Because if it's going to work, then you're going to know that, and if it doesn't work, you're going to know that before you get too much older, such that, all right, let's say you spend 2 years trying to figure it out and nothing works. Well, when you figure that out, you're 28 years old and you still have time to move forward. That's very different than a 38-year-old, 39-year-old, where by the time people hit 40, it's not like you drop off this magical fertility cliff when you get to your birthday every year. It's just a gradual decline, but the decline does start to get a lot steeper once you hit your 40s. And that can happen, frankly, at any time between 35 and 40. Usually by the time you hit 40, it's already happening. And so in that case, you may say, you know what, I really don't want to screw around, because I've had patients who've said, I'm going to check my fertility status every year and then make a decision based on that. Well, the problem with that is, as soon as your
You're
fertility
waiting till it's too late.
you're waiting till it's too late, because as soon as it's declined, it's already low.
Yeah.
And I don't have a time machine. I can't help that. And so that plays in as well. And certainly if you're in your early to mid 40s, it's let's get this show on the road as fast as possible so that we can get you the family you want.
Mm-hmm.
So, Susan, is there ever a time when you have seen a 25-year-old couple and you're like, you need to do IVF, and it's a pretty absolute
Absolutely.
reason?
Absolutely. So those are the times most often they are going to be, maybe you have damaged fallopian tubes, where your tubes just aren't going to be a wise thing for us to use. Maybe because of past infection, or maybe because of endometriosis, or maybe they're just blocked and we don't know why, but that's a big reason. Or if we have really poor sperm. So if we have less than 5 million sperm, and, either you don't choose to try methods to potentially increase sperm production, or time is important because of that, or you're just like, sperm's not good, that's IVF is a pretty reasonable option, and there's a 50-50 chance that even if we did give him medicine that we're still going to be doing the same thing in 3 months from now, that those would be some reasons why, despite age, that you would definitely need to be boogieing on towards IVF.
So, Carrie, are there any medical illnesses, maybe gynecologic, maybe not gynecologic, that would make you go, yeah, you're young, but you really still need to move on and do IVF sooner rather than later?
Sure. Sometimes people have premature ovarian insufficiency, where they have just very severely decreased ovarian reserve, in which case we want to move quickly and take advantage of whatever we can get. Sometimes people have genetic disorders. So think of the BRCA1 and 2 genes, where those patients are much more predisposed toward not only not only breast cancer, but ovarian cancer.
Mhm.
And oftentimes the recommendation is to pull out their reproductive system as soon as they're done having their family. Endometrial cancer is another one where people who have stage 1, where they can get by with just progesterone treatment. Typically, the oncologist will say, have your family do it now, and then as soon as you're done, we're gonna yeet the ute, as one of the aunts in my area says. So pull the uterus out. Um, Anything that is a degenerative type of disease usually begs the question of, can we get our fertility dealt with now? Can we start building our family now? So sometimes that is lupus, where
Mhm.
you happen to be in a good spot, you've been stable for a year or two, and let's get this out now, because God forbid you become unstable in the future, you have kidney disease. Some of those meds are extraordinarily toxic to the ovaries. Like, they will save your life and they are absolutely worth it, but they will kill every last little egg you have.
Mhm.
And so whenever you're at a period of, okay, everything's good, things are stable, let's do the pregnancy now and take advantage of that. So those are just some of the medical
Mhm.
conditions
Yeah.
that are
So
relevant.
Susan, Carrie hit upon genetic conditions. Kind of what kind of genetic conditions could we help treat or correct with IVF? And why would somebody want to do IVF if they have some sort of genetic condition?
Right. So, kind of, I think what Abby's kind of hinting at is sometimes people are carriers for certain recessive genetic conditions. So, when we look at genetic conditions, generally speaking, there are some exceptions, but there are recessive and dominant genetic conditions. Dominant conditions are ones that you only need one copy of, and those fortunately are pretty rare. Usually, we think of things like that, like Huntington's disease, which is a degenerative neurologic disease. Um, but what we're really kind of focusing on a lot of times are the recessive diseases, and that's where the person who's contributing the egg and the person who's contributing the sperm are both carriers of the same condition. And in that type of situation, you would have, say, a 25% chance of having a child with a significant disease. We think of this with things like cystic fibrosis, spinal muscular atrophy, Smith-Lemli-Opitz. There are hundreds of these diseases, and we have amazing screening techniques for these things that a lot of us use when you come to our clinics. And sometimes people come to us because they've actually had a child who has been born and passed away from one of these serious diseases. So the neat thing is that we can actually test both partners, have a probe made that's specific to their genetic locus, the specific location of their genetic abnormality, and we can test the embryos so we know if the embryo does not have any carrier status, or if it carries one, or if it carries both copies, and then we can selectively transfer embryos that would not be affected. So either one that doesn't have anything or only has one copy, because then they're just going to be just like you. And so that's a great option.
Okay. So we've talked a lot about medical conditions, and we're medical doctors, so we're more comfortable talking about medical reasons. But Carrie, can you speak a little bit, like if somebody's listening for the first time and they're thinking, "Gosh, I really can't afford IVF." What are your thoughts about that, and what should they do? Where can they get some information about that?
So the financial part of this is oftentimes one of the hardest things, because IVF can
For
be
us, for sure.
incredibly expensive. And as physicians who, all we want, I think all three of us would say the vast majority of the time, our preference is to say, yes, you should do IVF. But the reason we come up with ways to backbend around it is because of the financial.
Mhm.
Um, Places that you can go to talk about this. So let's say you don't happen to have a money tree in your backyard, and this is going to be a stretch. So look on the Resolve website, look on the Livestrong website, start to look at particular grants that may be available. And that's going to vary city by city, state by state, ethnic subgroup by ethnic subgroup. Sometimes you'll find the, you know, Polish, Jewish, blonde-haired, skateboarders association. And hey, I'm a blonde Polish Jewish skateboarder, and I'm gonna apply for this. And some of them really are arbitrary.
Yeah.
And so just looking around and seeing what you can get, and also having a very frank discussion over what what is the value of money here, because there are some patients who are going to say, look, there is no way I will ever be able to pay this back, and I just can't in good conscience do this. And there are other people who have perhaps a really conservative upbringing with respect to money, but when they really stop and think about it, they know, they realize, you know what, money can be earned. And at this point, if I do this now, I will have a much better success rate than if I do this in, say, 5 to 7 years when I'm able to save for it. And so we're going to take the plunge. But it brings up not only all of the relationship issues and the medical issues, but it brings up a lot of money issues as well. And people don't realize just how deeply ingrained that is in who you are as a person, because it goes back to how you were brought up, what your current situation is, what your situation was as a child. And it brings a lot of stuff to the surface that's very uncomfortable. So starting to look around and saying, okay, how can I reasonably work with this? And the financial office of your fertility center is going to know what agencies are open to working with people for funding for this. And so
So there are loan programs available specifically for people who are seeking fertility care. So that kind of help break up the price. So it's kind of like a car payment. I mean, unfortunately, IVF is the price of a small car. And so, these loan programs are available. Generally, obviously they're going to do a credit check on you and that type of thing. I think usually you have to be a US citizen to qualify. Sometimes we have patients who that's an issue as well. But, going in and a lot of the money part also depends on, your timing. Is this something that you can work on? Can you save up for 6 months and you would be much more comfortable, or is 6 months potentially detrimental? But the other thing is there are more and more companies out there, employers that are opting to include fertility coverage in their program. So one thing I'd like to kind of dispel a myth is we'll ask people, what type of insurance they have. And they'll be like, oh, I have Aetna, Blue Cross Blue Shield, but they'll name all the carriers. Well, the carrier really doesn't make that much difference. Your employer tells the carrier what they want to have covered. So if you want to fight for fertility coverage, you need to fight with your employer, not, whatever insurance carrier you happen to have. And sometimes, we've all had patients who have found out that they needed to have certain types of, whether they needed to IVF or whatever, and they've gone and looked for jobs at employers that have coverage. And, sometimes it comes down to trying to decide what's the most important, you continuing your job at the place that you are, or, potentially looking at other employment options. But know that is something, and that's going to vary regionally. Okay. There are certain states in the US that are mandated states that all employers have to have fertility coverage. All three of us do not live in mandated states. And so we deal with this, on a daily basis. Every single person who comes in, finances is part of the
Issue for
decision
everybody.
on whether or not they do IVF. And sometimes you may ask family to help you. Your parents often are very excited to potentially have grandchildren, and they might help. It's one of those, again,
absolutely.
we like to keep everything private, and we completely understand that, but sometimes sharing your struggles can actually get you some help. So, that's not everybody's family, and I completely recognize that, but the drive to become grandparents is amazingly stronger than you would think of in a lot of situations.
Well, the one thing I'll say in Tennessee, I never thought I would see the time in my career where I would have so many people that had such good coverage for IVF. It's really like dominoes falling. It's like
Mm-hmm.
now, one group of teachers in one area, they've gotten, they have great coverage for IVF. And now the other teachers in the other areas are like, well, if they have great coverage, why don't we? And so it's almost like it's almost peer pressure for the employer because the teachers in this area are going to leave their jobs and go elsewhere. Same thing in the community. We have 3 hospitals that cover great coverage for IVF and one that doesn't. And I have had several patients that are nurses that have left that particular hospital and gone to the other hospital where they had complete coverage for IVF. So sometimes it's not a huge change in your job situation, but just look around because more and more people are starting to cover IVF, which is great. It's fabulous.
Right.
So I think we covered that area pretty well. One last thing I wanted to mention, and this is again not a medical topic, but more of a personal topic. And I think we have all seen patients who have had religious beliefs that it's made it very difficult for them to think about doing IVF. Susan, what can you say about that? What should people think about? And what are some things that we can do as providers to kind of help them if they share that information with us and let us know what they're concerned about from a religious perspective?
Right. I think it comes down to kind of two main areas. Okay. So when I have patients who come to me and they are having religious qualms about doing IVF. So one is whether we should do IVF or not. Okay. That's one group. And the other group has to do with leftover embryos. Okay. And so when it comes to the should we do IVF or not? I mean, I can say that I'm a Christian and my belief is I am an agent, I am a tool. And whether a pregnancy happens or not happens is not actually up to me. Okay. I can do everything I possibly can. I've been given, amazing knowledge and an amazing lab and amazing staff, and we can do all the things. Okay. And whether that embryo becomes the baby that you're dreaming of is not, like I said, it's not up to me. I'm here to help that process. But you have to make that basic decision on your own between you and your partner if you have one. Okay. And sometimes that involves going and talking to, your religious leader and finding out what exactly is allowed or not allowed and that types of things. Because I would have to say that sometimes within certain religious communities, what a congregation feels and what your church actually,
Practices.
supports or practices can be vastly different.
Yes.
I mean, I personally belonged to a church previously that the general air was relatively anti IVF. But when I would go and talk to our pastor was like, he had a very similar feeling that I did. And I was like, this is really interesting. So again, you get that basic, is IVF okay or not okay? All right. But then you also have the part where it's like, what do I do with embryos? Which embryo disposition is its own episode.
Yes.
But this is one of the big things to talk to your reproductive endocrinologist about, like, because we can do things like limited insemination and freezing eggs and things like that. Now, these decisions often come at a financial cost. Okay.
Mhm.
But there are ways we can make sure that you don't have more embryos than what you want. And we can work through different things. Okay. But talk with your reproductive endocrinologist. And some of these, I don't want to get into anything specific here because so much of it depends on how old you are, how many eggs we expect to get, if you've done cycles in the past, that we have any track record. There's lots of things that go into that. But you and your reproductive endocrinologist, that it's kind of one of those like, I at most want to have blank number of children. What do I need to make sure that that doesn't happen for me to have remaining embryos? But then also having that discussion about embryo disposition, because sometimes there is something that you would feel comfortable with if you had excess embryos for the future.
But one thing we can say more specifically, I think kind of what you're alluding to, is we can limit the number of eggs that we fertilize. But as Susan mentioned, depending on your age and kind of the quality of your eggs, quality of the sperm, we don't have a crystal ball. So we can't say if we fertilize 3 eggs, you're going to have 1 normal embryo. We can't say that. So, I've had situations where that's worked great. I've had situations where we had really poor fertilization and no embryos because we limited the number of eggs that were fertilized. Because I do think the patients that I talk to from a religious perspective, the biggest concern, if there's, everybody has a different kind of bent on things, but the biggest concern, like you said, is people feel really uncomfortable a lot of times having embryos that are frozen. And, that's where I'm a Christian too. And that's where I say, I also went through IVF. Both of my kids were frozen embryos at one point. And when we freeze embryos, it doesn't mean we kill the embryos. In fact, to the contrary, the reason we freeze those embryos is so we don't have to discard them. We can use them at some point in the future. And that's exactly what happened with me and my 2 children. They were frozen embryos at one point. We thawed them out and transferred them. And so, I think if you had, it's a different story. You've had 2 or 3 frozen embryos versus if you had, and this would be really unusual, but if you had 8 or 10 normal embryos, a lot of people would say, I'm not up for having a football team or a basketball team, and I don't want to discard these embryos. And that's where it gets to be a lot more complicated. But again, like Susan said, your doctor can talk to you about that in your own kind of unique situation. So any thoughts, Carrie, on that, or any other questions you may want to ask if you're thinking about doing IVF?
I think one of the things that really helps people clarify their decisions is to ask themselves, what is my priority and what is my value? Because most of the time, once people identify the value that they have, whatever it is, it clarifies exactly what they should do next. Because when I have somebody come to me and they say, this is my value, this is what is really important to me, then my job as a physician is to say, okay, this is how we streamline to that value, which is what you hold important, which can be very different than what the patient before you and after you holds different. And that applies to a lot of the religious component of this as well, because oftentimes the churches they're not scientists. They don't keep up with every available,
Technique that we
innovation
have.
in medicine and every advancement. But they do know what their values are. And so you identify the value that's important to you, and then we work to that value.
Absolutely.
Very good. Well, to our audience, thanks for listening. Tune in next week for more, and be sure to subscribe and leave a review in Apple Podcasts. We'd really love to hear from you. We're also on Instagram, Facebook, YouTube. Be sure to follow and subscribe.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We also love episode ideas, so let us know what you're thinking and want to hear. And listen up to our hot breaking news. We are planning a conference in New Braunfels, Texas, right in between San Antonio and Austin. It's going to be October 28th, 2023. Mark your calendars. Come hang out with us for the whole day. It's going to be everything you get in the podcast and more. We'll be speaking and we'll have some amazing guests. There'll be lots of interaction. We can't wait to see you here. Keep your eye on the website and social media for more information about registration.
As always, this podcast is intended for entertainment and is not a substitute for advice from your own personal physician. All right, we'll talk to you soon. See you next week. Bye.
Bye, everybody.